Okay, Dr. Rachel Rubin, I am honored that you said yes to my request because I I like to keep up to date on the current literature and hearing what's going on in the pelvic health world. And I've heard your name and heard you talk on so many different platforms, and I'm always so much in awe about all the with all the time you take to be able to advocate for women. And I saw you one time say something along the lines of anybody that wants this broadcasted on their podcast, ask me. And it's like, oh, I'm going to ask her. And so I appreciate you saying yes. And for anyone that doesn't know you, will you take some time to just help everybody understand who is Dr. Rachel Rubin?
Sure. And I'm so honored to be here. I believe Canada has the absolute best sex research and best sex researchers out there. So I am jealous that I'm not Canadian. I'm Dr. Rachel Rubin. I'm a urologist who is fellowship trained in something called sexual medicine, which means I do comprehensive sexual health for all genders. That could range from menopause and hormone issues, low libido, orgasm problems. I do a lot of pelvic pain, erectile dysfunction, you name it, we can take care of it in our office. And we very much focus on the biopsychosocial approach, like really looking at people, which means spending time with them. I started my own practice because in the United States, medicine is these quick 10-minute visits, and you have to see 5 patients an hour. And I said, I don't want to play these games. And so I'm just going to sit in my little office by myself, hang out my own shingle, and try to do it my way, which has been incredible. We've been open about 5 months. So yeah, that's a little bit about me. I am the education chair of the International Society for the Study of Women's Sexual Health, or ISWISH, which I'm very passionate about. It's an incredible organization. Melissa, if you're not a part of it, you must join and become a member and be an active member. It's an incredible organization that is just focused to furthering the science, education, and advocacy surrounding women's sexual health, which is really excellent.
One of the things I always hear you talking about, shouting from the rooftops about vaginal estrogen, and this is a topic I've been wanting to do justice to for a long time. And of course, I thought about you. And I think I always like to tie in. I mean, my podcast is called the Pelvic Floor Project, and I always want to tie in what's the role of pelvic health physios here, because I think obviously we can't prescribe estrogen. This is not our expertise, but what brings clients, and let's talk about women in this situation, what brings them in to see us are symptoms, like, for example, pain with intercourse, stress incontinence. So they're leaking when they cough or sneeze or jump. Maybe they've been sent by a specialist for different reasons. They have urge, they have pain, symptoms of infection. And I find a lot of them are just on a health journey. Sometimes it's kind of my kids are out of the house now, things are going on in my body, and this is something on my list. And so obviously, like you already talked about the biopsychosocial model. And when people come in with symptoms, we know that there could be lots of different things that are contributing to this. And so maybe they're coming in thinking of their pelvic floor muscles, but the pelvic floor muscles are so often the victim in a much bigger picture. So I wonder if, like, I would like to tie in kind of, why, and one of the things we look at with not only our subjective history is asking questions about what are your symptoms, when did they start. And so honestly, you kind of have those ideas going off in your head depending on their age. I start thinking in the 40s, late 40s, early 50s, starting to pay attention to some of the other systemic things going on. But then when we do a vulvar exam, because the pelvic floor muscles live at the opening of the vagina and the anus. So when we look at those muscles from the outside, or touch those tissues from the outside, we can see tissue changes. And I find that's quite often when I say, I recommend you go back and talk to your doctor or talk to your specialist, because some other things are going on here that contribute to your symptoms. So I was hoping that you could talk about, like, why are hormones important in our body and in our tissues to start with, and then let's move on and talk about, like, what happens during different stages of our life, for example, menopause.
Thank you for the question. And I think physical therapist or physiotherapist, I don't care who's listening, it is essential that you understand how hormones affect the tissue because you spend time with patients. And I know Canada is no better than the United States in terms of the amount of time physicians get to spend with their patients. And so you get longer and you can really educate and you can teach patients. And so the best thing you can do is get a mirror out and show people what you're looking at. Teach them, say, hey, I went to a course. Hey, I follow this crazy doctor, at Dr. Rachel Rubin on Instagram, and you should follow her too, because she will explain why this is so important. And it's so basic, it's so simple, but nobody thinks about it. For example, I saw a patient just today in my clinic who was in her 60s, right? She doesn't have pain with sex. She's not that interested in sex, so she's not having any sex with her partner. And the last time was about 2 years ago, and it was kind of painful, but it's not why she came in. She's got urinary frequency and urgency. She's getting up at night, and her bladder's kind of ruining her life a little bit. And when you talk to her, she has done every treatment under the sun, physical therapy, every bladder installation, all of these medications, and she's no better. And so I said, what about vaginal hormones? And she said, oh, well, I used a cream for 2 days and it spazzed up my pelvic floor, so I stopped using it. And that's when my brain exploded and I went nuts on her, because nobody tries and fails vaginal hormones. The creams were not correct for this woman because they irritated her tissue, but the tissue is so hormonally sensitive. So here's how I explained it to her and how I'll explain it to you is babies, okay, baby vulvas do not look like adult vulvas. Baby vulvas have tiny labia minora. The opening is red, it's raw, it's irritated, and babies pee in their diaper all day long. And you put diaper cream just because it looks and sounds so painful when you look at it. Baby vulvas have no hormones at all. And then puberty happens, right? The surge of hormones, and your baby girls now become very mean to you. If you're their mother, they start talking back, but their bodies literally change. They transform. You grow labia minora. The opening to the vulva becomes pink. It lubricates. The vagina can then have tampons go into it. Sex can happen. Babies can get made. And so it is hormonally sensitive tissue, right? And it is hormones, and not just estrogen, but actually testosterone as well, that causes that tissue to grow and morph and change. And so then different life events can happen. If you have a baby and you breastfeed, that puts you essentially in a menopausal state where you don't have hormones. So you may experience vaginal dryness and pain. You lose the acidity of the vagina to fight urinary tract infections. And you can feel like you have a urinary tract infection even when you don't. And so then menopause hits for real, and you lose the hormones in your body. And it's essentially your tissue going in reverse. And so it's dry, it's irritated, sex is painful, urinary frequency and urgency happen. And so for this woman that I saw who is 60, in her 60s, I said to her, I said, your muscles will never get out of spasm unless you get the tissue healthy. So to your point, Melissa, the muscles, as you know, are the innocent bystander. They're just responding to the fire. Okay, so the tissue is a fire, and the muscles are recoiling against the fire because they're trying to get away from this fiery tissue. And so I think, gosh, I will say physical therapists know so much more about this now than they did 5 years ago. Even 10 years ago, forget it. There is so much more improvement in the training that you all get, and I think social media has been essential for sort of that education of saying it actually is the physical therapist's responsibility to understand the hormone connection and to help their patients advocate, because unfortunately the doctors are not bringing it up and are not thinking of it.
Well, and I think that there's this misunderstanding too, that when you hit a certain age, there will be a test done, and that your hormone levels will dictate then that you need to take, you may or may not need to take some type of hormone therapy. But I mean, the more we're hearing about, well, no, you have to treat the symptoms, right? And there isn't a certain age that, okay, now at 47 years old, you must start taking some type of, hormone cream or hormone therapy. So I think at the end of the day, being able to understand your own symptoms and changes, right?
And also understanding that different hormones are different, and local hormones, either a vaginal estrogen tablet or a vaginal estrogen ring or a vaginal estrogen cream, which the creams are my least favorite because they're kind of goopy and women don't often keep up with them, but it doesn't harm anyone. It's actually never been shown to harm anyone. It is totally safe. And so you could start it at 45, you could start it at 50, you could start it at 60. I've started a 98-year-old woman on it because she had vulvar pain, and and urinary symptoms, and she did fabulous. I see her once a year, and she's so much better. And so I think the key is there are many reasons to or to not be on whole body hormone therapy or birth control pills or things like that. But and we could have that conversation as well. But local vaginal hormones are just that. They're local, and they treat the bladder and the urethra and the vagina, and they create a healthy microbiome to keep the tissue acidic and strong and healthy so that you can fight infections, so that sex can be comfortable, right? This is the best form of vaginal rejuvenation that you can do, is keeping your tissue strong and plump and healthy, so that you can urinate without, when you want to, and not all night long, that you can make it through a movie, that you can sit without pain, right? Those are the things that we're doing when we give this local hormone therapy.
And I think again, there's a misunderstanding that like all of these tissues that you've mentioned, the vagina, the urethra, the vulvar opening, even around the anus, like there are receptors that are looking for estrogen to stay healthy. And it just happens, whether you have a nice, easy menopause or not, you don't make the hormones, right? Like that's what perimenopause and menopause happens, right? And so you're not, the receptors aren't getting what they're looking for, and that the creams or the rings or the inserts are meant to replace what was there, right?
Absolutely. And again, and if estrogen is sometimes not enough, because there's also testosterone receptors down there, and that's when it
Yes.
gets a little trickier and a little more expert care needed. But the very basic foundation is a vaginal estrogen for most people. There is a product that's also vaginal DHEA. It's a Canadian company that created it, and it's wonderful, and which is also a great product. So vaginal estrogen or vaginal DHEA are wonderful products that can be used by literally anyone, even people with breast cancer, even people with blood clot history, even people who've been told they can never use estrogen, or they can. And it's obviously a conversation you need to have with your doctor, but there are no data points on earth to show danger. And that's really where my advocacy work is, because I believe that we could save lives, right? That 90-year-old woman in the nursing home who gets a urinary tract infection and goes to the hospital. I want to prevent that. And I believe I can with lifelong vaginal hormone therapy, which now has become much more affordable in the United States because of pharmacies like Mark Cuban's new pharmacy, Cost Plus Drugs, which allows an online pharmacy outside of insurance to have medicines that's less than $10 a month, which is amazing.
Yeah, and I'm not sure if it was you or someone else I was listening to pointed out too that we just live so much longer beyond our reproductive years too, that it used to be that as females we just died earlier, and so we might not have noticed some of these symptoms as long into our life. Is that
Yes
right?
and no. Yes and no. That data is a little bit, not always the case, right? There's lots of people who lived into their 80s and 90s and 70s and things like that. But the key is there are a lot of things that we could say, suck it up, it's just aging, right? I could take out my contact lenses. You could take off your glasses and say, well, ladies, come on, you can't see, it's fine, just suck it up. We can't be productive members of society, right? You could say, hey, go walk to work because, the car is technology you don't need. Like, just do it the way that we used to do it, with a horse and buggy. Like, we don't do that. We use technology to
Right.
make our lives better. And menopause, much of it is about quality of life issues. But I believe the bladder issues are not just quality of life issues, they are life and death issues, right? If you are peeing all night long and you are not getting any sleep, that will impact how long you live, right? If you are in your 90s and you're getting up to urinate all night long, and you slip and fall and break a hip, that is a life-threatening issue. And so I believe this is not just about quality of life, which has been the case, right? These medicines have been out since the 70s, and they're still used by like less than 6% of people who have these problems. And so what I try to do, it's funny because I'm a sex doctor. I love talking about sexual health, but what I try to do in my advocacy work around this is say it's not about sex, right? This is about bladder health. This is about urinary health, and make it cool to talk about. So anytime someone comes to a physiotherapist with any urinary symptom and they're over the age of 45, I want every physiotherapist to think, boom, this woman needs some kind of local hormone. She goes to her doctor says, well, you're still getting periods and you don't really need this, and there's really no indication for it. That doctor is actually wrong, right? There is proof that it can prevent urinary tract infections and that it can help local urinary symptoms. That doctor just is not up to date on the literature because there's a lot to learn. There's a lot to care about. And women's sexual health and quality of life issues is like very low on the ladder of what the medical community cares about.
I like that you mentioned, kind of, for any physiotherapist listening, there are obviously clients listening to this. Not almost every single client that comes to see me leaves with one of these podcasts, at least one, but there'll be physiotherapists listening. There'll be other care providers. There'll be clients. And so, you mentioned urinary symptoms. What about a quick list of a couple other things, over the age of 45? Summarize a couple of the symptoms that they should be watching for.
Absolutely. So this is what is called genitourinary syndrome of menopause. So that means there are genital and urinary symptoms that we look for. And there are the symptoms, which is going to be vaginal dryness, pain with intercourse, decrease in arousal and orgasm and desire. It's going to be, some people will have pain with intercourse, bleeding after intercourse. Some people have irritation, burning, and itching of the vulva and the vagina. And then you get into the urinary symptoms, dysuria. You feel that you have pain every time you urinate, like you're peeing on an open wound, or you feel like you have a urinary tract infection, but all the cultures are negative, or you are getting urinary tract infections. Even if you have urinary frequency and urgency, those are all signs of genitourinary syndrome of menopause. And for the practitioners listening, it's really important that, just like Melissa said in the beginning of the podcast, you can see this with your eyeballs. You can see a decrease in moisture and a decrease in elasticity. You will see the labia minora shrivel up and disappear. And anyone who's listened to me talk knows that I say if a penis shriveled up at age 52, we would have vaccines for prevention, right? Like, nobody talks about the fact that you lose your labia in menopause. You don't have it as a baby, you grow it in puberty, you lose it in menopause, and no one knows that, right? You see paleness right at the vestibular opening. You see paleness and erythema. In fact, I just sort of came up with a thought that you see a lot of paleness at the top near the urethra, and the bottom you see a lot of erythema. And I don't know why that is, but I want to figure it out. You see fragile tissue. You see the loss of the wrinkles or the rugae inside the vagina. So instead of those thick wrinkles that allow for that elasticity and stretch, you see very, very thin, paper thin tissue that is going to crack and bleed just with any kind of palpation. So if that person has mesh in her vagina or on her urethra, it may erode through if it is not healthy with vaginal hormones. And you will see urethral prolapse and caruncles, and you will see urinary tract infections. If you have vaginal pH paper, just regular pH paper in your clinics, and you could buy it on Amazon, you want the vaginal pH to be 4.5. It should be very acidic. What you see in your clinic is that they end up being like 7.5 and not acidic. And so you can really tell when your patients are getting the therapy. Maybe they say, oh yeah, I'm using that estrogen cream, and you check the pH and it's 7.5. They're either not using it or it's not absorbing in the way that it needs to, and they need to switch to a different therapy. And so you can see this with your eyeballs. So you look at the symptoms, you see what you see with your eyeballs, and the answer is therapy is totally safe. Why not do it? Because it's going to help. Now, it's important to know it takes 2 to 3 months to work. We did not build Rome in a day. The tissue needs to absolutely replenish itself. So it takes 2 months to work. So most women take something for a week or take something for 1 month. And then if it's not fixed, they throw it in the garbage, because why am I going to spend my money and my time with something that's not working? But it takes 2 months to work. So you have to give it the time, and it will not work if you don't use it. So if you use it for 2 months, you feel better and you stop it, it will not, the tissue will go right back to feeling terrible.
And I think that's something, like, I want to talk a little bit more towards the end about take home messages for people, but absolutely on that note, as someone listening who's going to start using hormone therapy, ask the care provider what their directions for use are, and then ask the pharmacist too, because that is one of the most common things that I ask people: are you taking any type of hormone therapy? When I remember, but I think that they just don't, they haven't, it hasn't been explained to them.
And most providers don't know how to tell you to do it right. And I yell at my urology colleagues. I speak to thousands and thousands of urologists every year, and I have a giant slide slide that says a dab of estrogen cream on the urethra is not enough. And I will fight anyone to the death. I will argue with anyone endlessly that you can put a dab on the urethra. That's fine. But if you're using a cream, you have to use at least 1 gram every day for 2 weeks, and then twice a week forever. So a whole gram, a little bit on the urethra is not enough to acidify the whole vagina and to fight infection.
Well, and I don't remember who I hear some of this from, but I loved the analogy. Someone said it's like it's like sunscreen. You need to think of it like sunscreen. And if all you do is put it a little bit inside your ear, you're not exposing all the other skin to the benefits of the sunscreen, right?
I love that.
You have to apply it to the areas that need it.
That's fabulous.
So you alluded to different options. So you talked about, you can have pills, you can have rings, you can have creams. And that once someone starts taking it, they need to take it forever. So let's talk a little bit about that. But first, if you talk a little bit more about the options, obviously the different countries have different options, have different medication options, but how would someone know? Do they normally start with just their preference? Do you normally say, here's your options, pick one? Or how does that usually go? Where do you start?
It's a great question. In the United States, we get a lot of pushback from insurance companies, and that kind of really drives where I go with patients in terms of what I start with. We have crazy rules in the United States of and every insurance company is different, and the amount of paperwork they want you to fill out for them to just deny a medication or charge an obscene amount of medication. So, for example, I often, when I teach and when I tweet and when I go on Instagram, I really like to tell people to keep it simple and do something that you're just going to know how to do every time. I got to teach ER doctors and residents and urgent care doctors. I want everyone to feel confident doing this. So I'd like to start with an estradiol 10 microgram vaginal tablet. It's a generic medication. It should not be more than $10 a month. You can use if you're in the US, you can use costplusdrugs.com. They sign up for an account. You put it through your electronic medical record, and boom, they get $10 a month of vaginal estrogen tablets or creams. So you can do the creams or the tablets through that pharmacy. And so I like the tablets because it's a 1 pill in the vagina every day for 2 weeks, and then twice a week forever, till death do you part. And so it's a really easy for people to remember. If at 2 months the patient is not doing a ton better, again, you examine them, you look at their tissue, you look at their vaginal pH. Sometimes we have to add and tweak and change things around a little bit. And sometimes we just send them to you because at that point, the muscles can really learn how to relax. So it's often that double therapy, the local hormones, and the physical therapy. That's the dream team sort of connection there. And so that's where I often start with patients. There's nuance, there's other ways to do it. Again, the vaginal rings, if they're affordable for your patients, are wonderful for your patient with poor dexterity or dementia, where they can't put something in their vagina. So you could put a ring in, it stays in for 3 months at a time, and you bring them in every 3 months and you take it out and you put in the new ring. So it's a fabulous option, but it's not always affordable, at least where we are. The creams, again, some women like creams. I have yet to meet one, but the creams are very often prescribed, but I find that they're a little goopy and gloppy, and women do not love creams. And then, the vaginal DHEA, I would give to everyone if I had access to it. The reason I love vaginal DHEA is because it adds an androgen component. Remember, I said the vulva, the urethra, the bladder, the vestibule, it has androgen receptors, testosterone receptors, not just estrogen receptors. And so sometimes estrogen is not enough. A lot of times it is, but sometimes it's not enough. So when you have that patient, and if you're listening, patient, and you're on vaginal estrogen and you're using it the way Dr. Rubin tells you to, and you still have problems, well, then we either need to switch you to something with an androgen in it, like DHEA. Sometimes we compound a cream that has some testosterone in it. And sometimes things like physical therapy and Botox injection, botulinum toxin injections to the pelvic floor. There's some other therapies that need to happen, but hormones are always the right answer. It's never, let's stop the hormone and try something else. It's find the right hormone and then add or tweak the therapy. It's never, nobody fails vaginal estrogen. I have yet to see it.
DHEA still needs a prescription though?
It does. So it's in the US, it's called Intra Rosa, and it's a wonderful product, but it is a prescription product. Yeah.
And tell me a little bit about your thoughts on compounded versus regulated, because I know there's lots of controversy around that, and I'm not sure that I completely understand that.
Yeah, so compounding pharmacies make up their own medications with their own bases in their own concentrations, and they're not really regulated, right? So there's no FDA that's going into the compounding pharmacy and saying, well, what's in the bottle? So if they have whatever's in the top of their bottle, may not be the same concentration that's in the bottom of the bottle. If they make pellets, there's no guarantee that what they say is in the pellet is actually in the pellet. And so there's just no you can't trust it completely. Now, that being said, if I do not have an FDA approved product that I can work or that my patient can afford, there are a few instances where I do compound products. If I have a patient who has such bad irritation to something and I have to compound it into a lower dose or into a different base or something like that, then yeah, I do work with a compounding pharmacist who I trust very much, and he knows my children's name, and he wishes me we wish each other happy birthday every year, and talk a couple times a week. But I do it for the therapies that either I don't have an option or I need a different option. And so it's rare that I use it. The time when I use it the most is when you have pain at the vestibule. The vulvar vestibule is the opening to the vulva, sort of the lining inside the labia minora, the entryway to the vagina. When there is pain in that tissue, and it's very common to have pain in that tissue, it's actually often not just an estrogen story, but a testosterone story as well. So if I cannot get vaginal DHEA because it's too expensive and the insurance won't cover it, I will compound a estrogen testosterone combination, a very low dose, like a tiny low dose that doesn't really go into the whole bloodstream, and I'll have patients rub it on their vestibule area, and it's very, very beneficial, and it's been published on widely, and in the ISWISH community we all use it, and we have excellent results. So that's really when I would use compounded products. When it comes to whole body hormones, there's a lot of controversy over this word called bioidentical hormones. And it's just a marketing scheme, to be honest, because there are many bioidentical hormones that are FDA approved. So all it means is that if I give you, Melissa, a birth control pill, I can't measure the level of those hormones in your blood. Okay. It's not the same. It's sort of a synthetic estrogen, a synthetic progestin. If I give you an estrogen patch or an estrogen ring or an estrogen cream that you put on your arm, and there are many FDA approved options for estrogen, it is bioidentical estradiol. So I can now draw your blood and say, check your estrogen levels. I want to see what your estradiol level is. And so that's what bioidentical means. The problem is in the United States, bioidentical has become synonymous with compounded products. And so if someone says, I want bioidentical hormones, in the United States, that tends to mean compounded products or pellets or things like that. But it's not true. There are many FDA approved bioidentical hormone therapy options, and that's for whole body menopause, just so we're clear. The vaginal estrogen, the vaginal DHEA, the vaginal estrogen, those are local. Those do not go through your whole bloodstream. They're not going to fix your hot flashes or your night sweats or or prevent osteoporosis. Does that make sense? It's
Yeah, absolutely. I think I see how it's very confusing though to the consumer, to the patient, and I absolutely, I respect your time, and I want to focus this conversation on like the vaginal hormone therapy, but I look forward to hearing your thoughts after this episode of like where to continue this conversation, because I do want to talk about more of the systemic options. But
it's very important because there's a lot of money to be made, and people
yes.
who charge people a lot of money for things that they could get for covered by their insurance or very inexpensive that are actually FDA approved.
And I wonder, you already talked about how postpartum women can mimic, like their tissues can mimic because of breastfeeding, can mimic, a menopausal woman's vulvar tissues. How often do you treat those women? Or how often do you just say, you know what, this is a time in your life, let's ride this out? How often do you treat them?
if they're in my office, I will always give them the option of treatment because I have no data showing harm. We give women who are breastfeeding birth control pills, which are very, very high dose synthetic hormones, and it's been fine, right? It doesn't change their milk supply. There's been no issue. Local vaginal hormones when you're breastfeeding is safe. It's not going to cause problems. We've got data showing it. And so why suffer? Why do we let these women suffer? And they suffer so much. And some of them suffer for 3 years, right? People are breastfeeding for a very long time. And so it's not me saying don't breastfeed. Of course, enjoy your breastfeeding journey for as long as you would like if you are able. But you have to understand that when you breastfeed, your hormones are essentially non existent. Now, some people, their periods come back a little sooner. Some people are less sensitive or more sensitive. But if you're breastfeeding and you have vaginal dryness and pain, don't suffer. Use local vaginal hormone therapy. And it's exactly the same as everything I just discussed. You could use vaginal DHEA. You could use estradiol 10 microgram tablets, one insert daily for 2 weeks, and then twice a week till your periods come back. Or you can use a vaginal estrogen cream, use at least 1 gram daily for 2 weeks, and then a 1 gram twice a week, until you're done breastfeeding. Don't suffer. It's not worth it. Run to your nearest pelvic floor physical therapist. They will save your life, right? If you get a knee replacement, you do physical therapy. You have a bowling ball or a watermelon come out of your vagina or your abdomen. Nobody talks about rehab. It's absolute insanity. And
Yeah. It's insanity just the way, having this conversation with you about, I think, you hear the term, this isn't rocket science. Like this is not something this doesn't have to be as controversial as it is.
So easy. What I do is
Yes.
so easy, and it boggles my mind that people like you invite me to podcasts to talk about this stuff, and that people keep inviting me back to different podcasts to talk about this stuff because it's so, again, I feel very blessed that I get to do what I do for a living, but I'm not doing brain surgery. I'm not, it's right. I'm not doing anything that's that hard. I'm just listening to people. I'm examining them. I say, what's going on here? What could be happening? And we get treatments and we stay up to date on things that work. Are we perfect? No. There's still lots of things we have to figure out.
And I think I know that you see the benefits to the treatments that you provide people. And I see too, I mean, how much that this changes their lives. So then obviously let's shift and talk about, so why this sounds like a no-brainer. So then why doesn't this happen? So gaps in our care, gaps in our medical system, gaps in the information, why are they there?
So there's a couple big reasons. So cost was a big issue in the United States for a very long time. It is only within the last couple of years that coupons have made these things more affordable. And now with, again, that Mark Cuban pharmacy that is really affordable, like super affordable. That's new. That's actually very new. So cost is a huge thing. These medications have been out since the 1970s. Okay. They're approved though for dyspareunia, pain with sex. You have to go to your doctor and say, I have pain with sex to get these medications. And even then, most patients aren't going to bring it up, and most doctors aren't going to think, oh, let's do vaginal estrogen, because they were never taught really how to do this. And so maybe the patient will take it, they'll use it for a month, and they'll throw it in the garbage. But remember, it doesn't work unless you keep using it. So cost, education, and knowledge that it's a bladder issue, that's completely new, right? Genitourinary syndrome of menopause was not the terminology until 2014. It used to be called vaginal atrophy, or of atrophic vaginitis. Those are still the codes that we use today. And so the really important reason why these are not used, and something that I advocate for, is there's a box labeling on these estrogen products that says if you use this therapy, you are going to get a stroke, heart attack, blood clots, dementia, breast cancer, uterine cancer, and you must use it with a progesterone. Nothing that I just said is true. There is actually not a data point on earth that anyone can point to me that shows what is on that box labeling is true. And so it's based on false data, but it's based on data from, if you take a hormone by mouth that is a synthetic form of the hormone that has both a synthetic estrogen and a progestin, like a birth control pill, and you give it to ladies in their 60s and 70s. It is very different from a local vaginal bioidentical local hormone that doesn't go through your bloodstream. And so the FDA refuses to change the box labeling, even though there is no data that shows harm for these products. And women go home, they see the box and they say, right, oh my God, I talked to my doctor for 10 minutes and they told me to use this cream, but they didn't tell me that I needed a progesterone with it. They didn't tell me about the stroke, blood clots, dementia. My cousin had a blood clot. I'm not taking this. And they throw it in the garbage, right? And so it is harmful because I saw a patient once. I love stories. I saw a patient once and she came to see me and I explained this whole thing to her. She had been given vaginal estrogen as a prescription 3 times. Each time she got the prescription, she looked at it, she put it in her drawer. She got it again, she put it in her drawer. She got it again, she put it in her drawer. She finally gets an appointment with me and I talk to her for an hour and I show her pictures and I show her diagrams and I explain everything I just explained to you about why it's so important. And she said, well, why didn't anyone tell me that? I didn't understand. I thought this was about sex for my husband. I don't care if he gets sex again. I had no idea why this was so important. So I said, okay, I'll see you in 2 months. At 2 months, she comes skipping into my office and I'll never forget it. She said to me, she said, holy crap, Dr. Rubin, it's about wearing pants again. I can wear pants. I haven't worn pants in 10 years. And she was thrilled. It changed her whole life, right? This was 2 months. I mean, it was just incredible how much benefit these women can get if as long as they use the therapy and they keep using it. So the box labeling is killing women. And so we must do more advocacy. And so if anyone listening knows someone at the FDA, call me. Let's have a meeting. So every avenue we have to yell and scream about this is really, really important.
Yeah, and that's why I appreciate everything you do, because I'm sure you hit your head against the wall so many times, right? And it's bad gossip that kind of taints everybody's experience, right? And I think too, you've touched on how our GPs not only don't have time, I mean, we expect them to know everything, right? And like that's a lot to carry, and that's a lot to keep up on, and to be able to consider someone's needs in 10 minutes. And so I can see how, I mean, everything has to go through them. But to be able to, you still wait a couple of weeks maybe to get into your GP, and then you think, oh my gosh, I have like 5 things to bring up. And you're right, the embarrassing things tend not to come up, right? Because you feel rushed, and who wants to talk about the embarrassing things even with their best friend?
And your GP is going to care about your high blood pressure, your diabetes, your heart disease, all, your hernia, your surgery, the things that are going to kill you immediately. Your GP is not bothered by the fact that you wake up twice a night to urinate. Your GP is not bothered that sex is painful. And so unless you make it a priority and you say, well, I listened to this podcast and this is what I learned, and here's this blog post or this Twitter thread, just go to my Twitter, my pinned tweet, just take that to a doctor and have them read it. Within 5 minutes, every doctor can learn why GSM is important to treat and how to treat it. That's the thing. I try to make it as easy as possible. And so I want to teach thousands of doctors, millions of doctors, if I can, that this is their lane, that they can do this, that they don't have to fear. There's no labs you have to test. There's no exams that you absolutely have to do, although it helps, but you don't have to do it. And it's safe and it's effective and it works and it's so easy. And yet less than 6% of women are doing this.
Mm-hmm. And I think you mentioned too that, I mean, a vulvar exam is helpful. And I think, again, to do something so sensitive as look at someone's genitals in 10 minutes can be hard, right?
It's very, very challenging.
So I appreciate that you're changing things. And I mean, you, like you said, you're educating not only the general population, but other healthcare providers. And I've noticed that there's so much more information. So it's easy to send people. And I find myself always saying, just educate yourself. That's the best thing you can do, is educate yourself so that you can kind of help direct your care. You can help ask for things and feel confident asking for them. And I also appreciate, I'm hearing the term biopsychosocial so much more too, that we're looking at people holistically. And it's like you said, not just about having sex, but what's the quality of life of this person in front of us. And so I appreciate that you're bringing that term to other healthcare providers, because it's not a term used very often. You don't hear it a lot. It's more about body parts, right?
And I think it's also really important that patients learn to advocate for themselves
Yes.
and learn to realize that they are in the driver's seat and that all their team members are a pit crew, right? They're in this nice fancy sports car. If you're like me, you drive a crappy Subaru, and you have to have a pit crew that comes and helps tune you up. And it's not going to be just one team member. It's actually, if it's just one team member, you're not going to do that well. But sometimes you need a mental health provider, and you need a physiotherapist, and you need a urologist, and you need a primary care doctor. And so you need someone to help you with exercise and eating right, and it's okay to ask for help, right? Coaching is how Michael Jordan got good at basketball, right? Coaching is how people do things to learn new skills. And so think of your health and wellness as finding people to support you, to cheerlead you, to advocate with you. And I think that's really important. They can't advocate for you, but they can advocate with you and say that you do deserve better, which is why it's so essential. I think every physiotherapist and physical therapist, my partner in this detective work that we have to do, because nobody taught me as a urologist about the hips and the spine and the low back. Like, it's pathetic, right? How little I know as a doctor. And I think part of my magic superpowers as a doctor is that I say I don't know constantly. I am constantly saying, I just don't know. We don't know. This is where medicine is just like, let me call my friend and find out. Like, that's really important to have your doctors willing to say.
Any other action plan items for listeners? So be an advocate for yourself, educate yourself about the information. I think one of the things you also said was look at your own vulva, pull out a mirror and look at yourself, right? Because I think sometimes to have a baseline and understand what your own anatomy looks like, because men have the ability to look at themselves all the time. We just don't look, right? You mentioned everybody's an individual. And so no two people the same. It matters symptoms more than anything. Is there anything else, action items for people listening that you want them to take out of this?
Just remember, pleasure and sexual health is just health, right? You deserve joy and pleasure and intimacy and love and connection, and you deserve to feel good, and things should feel good. And yeah, you might have cancer or blood clots or high blood pressure. And if you want to still have an orgasm, you deserve to have an orgasm. And if it's not working, you deserve to see a provider that can help you understand it and help you try new things. And so I think under advocating for quality of life measures, and if your sexual health is bothering you or you feel that there's something wrong, seek out a professional, of someone who will really, really spend the time with you. Because, and there's some great people in Canada. There's a woman, Stephanie Hart. Dr. Stephanie Hart is incredible in Canada. There's so many other people whose names I am not coming up with right now, but I'll give it to you for the show notes, who do sexual medicine, who love to do sexual medicine. And so if you go to iswsh.org, isswsh.org, there's a find a provider. You can find all the people in Canada, and there are quite a few. And I think really helping to find people who care about these issues is so important.
And on that note, I'm going to make sure that I add in the show notes how to find you through all your social media avenues. But then as far as where do you practice? I don't think you mentioned that at the beginning. What city do you work out of?
Of course, I didn't mention that. So I'm in the Washington, D.C. area. Please come reach out to us. We'd love to work with you. You can sign up for our newsletter at rachelrubinmd.com. So our website is rachelrubinmd.com. And please, on all the social media channels, we'd love to hear from you. I do them personally. I can't always keep up with messages, but I try. Sometimes you catch me in a good moment. But it's Dr. Rachel Rubin. So Dr. Dr. Rachel Rubin, RACHELRUBIN. So would love for you to connect with us. And this has been so lovely.
Do you do telemedicine as well? So people outside of the DC area?
We do consultations in the sense that we'll listen to your story and we'll really try to come up with a plan and education surrounding what's going on with you. And certainly happy to have you travel. I have lots of people traveling in from all over the world who, say, gosh, like I have clitoral adhesions or I have pelvic pain and no one's been able to figure this out and I don't know what to do. And it still drives me nuts that people have to come and travel to see me. It's an honor, right? It never gets old. It's always an honor, but it's always frustrating when that's why I do so much teaching, because it cannot just be a handful of us. We have to clone ourselves. I have med students working with me who I'm trying to mentor and train and get excited about this stuff, because it can't just be a handful.
Well, I thank you so much, just not only for the time you've taken tonight out of your own personal life to do this for my audience, but also just everything you do for the whole cause, because I can imagine how many hours you have put into this. And so honestly, thank you for everything.
It's not work when you absolutely are passionate and love what you do. And I could scream this all from the rooftops. You don't want to see me at a birthday party or on the street. I will talk about vaginal estrogen. And so if you are listening and you are passionate about this and interested, your voice matters. And we need you to get involved. We need an army of people to give a crap about women's health, women's sexual health, men's sexual health. We need people caring about this stuff because quality of life is important. And so whether you're a patient advocate or a provider of any type, you can get it more involved. And I would love to see and promote you and support you and watch that happen.